Good day everyone, I'm Grysson Cañete and I am here today to report on hepatic cancer. Now let's start with what is hepatic cancer. Now there are few cancers that originate in the liver. Primary tumors usually are associated with chronic liver disease, hepatitis B and C, infections, and cirrhosis. Now the most common type of primary liver cancer is hepatocellular carcinoma, which is responsible for 75% of all liver cancers. Now this is also the third leading cause of cancer-related mortality worldwide. Now, there are other types of primary liver cancers which include fibrolamellar carcinoma, angiosarcoma, hepatoblastoma, cholangiocellular carcinoma, and combined hepatocellular and cholangiocellular carcinoma. Next off is the predisposing or the precipitating factors. Now, under predisposing factors we have chronic infection for hepatitis C virus. Now, under the precipitating factors is that we have first, cigarette smoking has been identified as a risk factor, especially when combined with alcohol use. Now, last is the exposure to certain chemical toxins such as vinyl chloride, arsenic, and most especially aflatoxin. Next is the pathophysiology, which we will break down into two. Which is first is we're going to have the hepatocellular carcinoma, which is the number one type of liver cancer, and next is we're going to have the liver metastasis. Now, for the hepatocellular carcinoma is that chronic exposure of the liver to injury from viral hepatitis, alcohol abuse, or NASH causes repeated hepatocyte damage and sets up a vicious cycle of cell death and regeneration, which eventually results in cirrhosis. The resultant genomic instability leads to initiation of HCC. Then stepwise accumulation of multiple genetic events include gene rearrangements, somatic mutations, copy number alterations, epigenetic changes, and growth factor pathway alterations eventually lead to tumor progression and metastasis. Next on our list is liver metastasis. Now, when it comes to metastasis from other primary sites, particularly the digestive system, breast, and lung, are found in the liver 2.5 times more frequently than tumors due to a primary liver cancer. Now, malignant tumors are likely to reach the liver eventually by way of portal system or lymphatic channels or by direct extension from an abdominal tumor. Moreover, the liver apparently is an ideal place for these malignant cells to thrive. Often, the first evidence of cancer in an abdominal organ is the appearance of liver metastasis. Unless exploratory surgery or an autopsy is performed, the primary tumor may never be identified. Next is the clinical manifestations. Now, the early manifestations of malignancy of the liver include pain, which is continuous dull ache in the right upper quadrant, epigastrium or back. There is also weight loss, loss of strength, anorexia, and anemia. The liver may be enlarged and irregular upon palpation. Now, jaundice is present only if the large bile ducts are occluded by the pressure of malignant nodules in the hilum of the liver. Now, lastly is ascites, which develops when nodules obstruct the portal veins and or if tumor tissue is seeded in the peritoneal cavity. Next up are the diagnostic evaluations. Now first, when there is a hepatic cancer, there's an increased levels of serum bilirubin, alkaline phosphatase, and liver enzymes. Next is the alpha fetoprotein, is the principal tumor marker for hepatocellular carcinoma and is elevated in 70% to 95% of patients with the disease. Third is the ultrasonography and CT along with MRI are the most useful non-invasive tests to detect liver cancer and assess if the tumor can be surgically removed. Next is the PET scan to look for recurrent or metastatic disease. Next is, as the newer CT scans and MRI can demonstrate necessary vascular involvement of any tumor, invasive studies such as arteriography are no longer needed to determine resectability. Next is percutaneous needle biopsy or biopsy assisted by ultrasonography or CT scan may be done. Lastly, laparoscopy with liver biopsy may be performed. Next is the nursing management, which we have broken down into three, which are the nursing assessment, nursing diagnosis, and nursing intervention. Now first, for nursing assessment is we should obtain history of hepatitis, alcohol liver disease, and cirrhosis, exposure to toxins, or other potential causes. For second is we have to assess for signs and symptoms of malnutrition, including recent weight loss, loss of strength, anorexia, and anemia. Third is assess for abdominal pain, any right shoulder pain, and enlargement of the liver. Fourth is we have to assess for fever, jaundice, ascites, or bleeding. Now lastly, we have to note any change in mental status as precipitating hepatic encephalopathy. Next is the nursing diagnosis, which we have come up with three. First is acute and chronic pain related to growth of tumor, imbalanced nutrition, less than body requirements related to anorexia, and lastly, excess fluid volume related to ascites and edema. For the first nursing intervention is that we're going to focus on controlling of pain. First is we have to administer pharmacologic agents as ordered to control pain, considering metabolism through a liver with decreased function. So first, we have to take note that we should use caution and we should not administer doses more frequently than prescribed. And we should also monitor for signs of drug toxicity. Second is we have to provide non-pharmacologic methods of pain relief such as massage and guided imagery. Third is we have to position patient for comfort, usually in semi-Fowler's position. And lastly, we have to assess patient's response to pain control measures. Second nursing interventions, we're going to focus on the improving nutritional status. First is we're going to encourage patient to eat small meals and to take supplementary feedings such as Ensure. Second is we're going to assess and report changes in factors affecting nutritional needs, such as increased body temperature, pain, signs of infection, stress level, and we should also encourage additional calories as tolerated. Now lastly is we're going to monitor the patient's daily weight. Next on our list for nursing intervention is relieving excess fluid volume. First is we're going to monitor vital signs and record accurate fluid intake and output. Second, restrict sodium and fluid intake as prescribed. Third is we're going to administer diuretics and replacement of potassium as prescribed. Fourth is we're going to administer albumin and protein supplements as prescribed to draw fluid from interstitial and intravascular space. Fifth is we're going to measure and record abdominal girth daily. Sixth is we're going to weigh daily, watching for increases that indicate increased fluid retention. And lastly is we're going to monitor laboratory values pertinent to liver function. Next is the patient education and health maintenance. So first is we're going to instruct patient and family on preparation for surgery, reinforce and clarify surgical procedure proposed, and review post-operative instructions. Second is we're going to instruct patient and family on non-surgical treatment if appropriate. Third is we're going to explore pain management options. Fourth is we're going to inform patient of signs and symptoms of complications. Fifth is we're going to instruct in continued surveillance for recurrence. And lastly is we're going to instruct patient and family in care of tubes or drains. Now, in any nursing intervention is we also have to evaluate. Now, for evaluation, our expected outcomes are such that the patient verbalizes reduced pain, the patient tolerates small feeding, and there is no weight loss already. Lastly is we're going to have the abdominal girth decreased, and we should make sure also that the urine output is greater than the intake. Next on our list is the medical management or interventions. Now, first is we have radiation therapy. Now, the use of external beam radiation for treatment of liver tumors has been limited by the radiosensitivity of normal hepatocytes and the risk of destruction of normal liver parenchyma. Next is we're going to discuss the chemotherapy, which is typically studies of patients with advanced cases of liver cancer have shown that the use of systemic chemotherapeutic agents leads to poor outcomes. Now, for patients with stable hepatic function, a targeted molecular therapy, which is with the sorafenib or the Nexavar medication, has been developed and approved for use and has shown some degree of improvement in treating patients with HCC. Now, next is we have percutaneous biliary drainage. Now, for percutaneous biliary drainage, percutaneous biliary or transhepatic drainage is used to bypass biliary ducts obstructed by liver, pancreatic, or bile duct tumors in patients who have inoperable tumors or are considered poor surgical risks. Now, lastly, we have other non-surgical treatments. First is the radiofrequency thermal ablation. Now, in radiofrequency thermal ablation, a needle electrode is inserted into the liver tumor under imaging guidance. Now, the radiofrequency energy passes through the non-insulated needle tip, causing heat and the tumor cell death from coagulation necrosis. Next is immunotherapy, which is another treatment modality under investigation. Now, in this therapy, lymphocytes with anti-tumor activity are given to the patient with hepatic cancer. Tumor regression has been demonstrated in patients with metastatic cancer for whom standard treatment has failed. Now, lastly is the transcatheter arterial embolization interrupts the arterial blood flow to small tumors by injecting small particulate embolic and chemotherapeutic agents as prescribed previously into the artery supplying tumor. As a result, ischemia and necrosis of the tumor occur. Now, for multiple small lesions, ultrasound-guided injection of alcohol promotes dehydration of tumor cells and tumor necrosis. Next is surgical management. For surgical management, we have 3 surgeries under this, which are surgical resection, local ablation, and liver transplantation. Now, for surgical resection, it is the treatment of choice when HCC is confined to one lobe of the liver and the function of the remaining liver is considered adequate for postoperative recovery. In the case of metastasis, hepatic resection can be performed if the primary site can be completely excised and the metastasis is limited. However, metastases to the liver are rarely limited or solitary. Capitalizing on the regenerative capacity of liver cells, some surgeons have successfully removed 90% of the liver. Now, next is the local ablation. Now, in patients who are not candidate for resection or transplantation, ablation of HCC may be accomplished by chemicals such as ethanol or by physical means such as radiofrequency ablation or microwave coagulation. Lastly is liver transplantation, wherein this treatment involves removing the liver and replacing it with a healthy donor organ. Liver transplantation offers good patient outcomes. Candidates with liver cancer meet stringent selection criteria, including having small, early-stage lesions. Now, lastly, for our report is the prognosis. Now, we always have to take note that if found early, resection of primary liver cancer may be possible. However, early detection is not common. Thank you for watching my report, and I hope you have learned something from it. Thank you and have a great day.